Yeah, my name is Dr. Innocent Mkonwa, and I'm the District Health Officer for Luweero District. Malaria Action Program for District, which has been a project working with us, has impacted a lot in improving health outcomes in our district. A number of interventions have come on board, and like one of them has been test and treat. And in the test and treat approach, what has happened is that we do not treat any person in our district without a positive malaria test. So as a result, this has led to reduction in the consumption of the consumables, like that is the drugs that we use for malaria treatment, because we are only giving those ones who need the drugs. We have also seen an increase in the number of mothers who are having live birth. Reason being that interventions like IPT have been strengthened. Thirdly, we have also seen that with the support of Malaria Action Program for districts in Luweero districts, they have built capacity for the health workers. Mentorships have been conducted, on-job trainings have been conducted, we have had coaching and all these things. And in the different fields, we have had approaches where we have targeted the people in the laboratories. We have had approaches where we have targeted people who have managed the data. We have had approaches where we manage the people who do clinical work. And as a result, the capacity of the health workers who are delivering services in malaria treatment has really been boosted so much. And meaning that we give more quality service compared to before MAPD came on board.
Good afternoon. You are all most welcome to this very important event this afternoon, which is the closure event of the USAID's Malaria Action Program for District program that has been taking place in Uganda in 52 districts. And this started in August of 2016 and is closing this afternoon. So you are all most welcome. The purpose of this event is to highlight the achievements of the investments that the US government put in malaria prevention and control in 52 districts in Uganda. This afternoon, we have a short program for the next 1.5 hours, and I will request that we stick to the time that has been allotted for each person that will either be making remarks or presentations so that we can get through the program in the next 1.5 hours without missing any particular item. I suspect we now have most of the participants that are supposed to be with us this afternoon, and I would like to welcome all of you once again. I'll start by introducing myself. I'm Dr. Godfrey Magumba, the Malaria Consortium's Regional Director for East and Southern Africa, as well as the Country Director for Uganda. And I'm your chairperson for this event this afternoon. So I would like to take this opportunity to introduce the participants that we have this afternoon. I'll not be able to introduce individual participants, but I will introduce the participants in groups. We have the US government participants, and I would like to request Dr. Kassa to introduce the team from the US government.
Thank you, Godfrey. It is indeed a special privilege and a pleasure to introduce the virtual participants from the US government. The US Ambassador to the Republic of Uganda, Natalie Brown. Thank you, Madam Ambassador, for being with us today. Lisa Nielsen, CDC Director. Monica Azim, USAID Uganda Acting Deputy Mission Director. Alicia Musa, Acting Director, USAID Office of Health and HIV. Thank you, Lisa, Monica, and Alithia for being with us today. PMI Uganda team in Kampala, Washington, and Atlanta. We have also USAID Development Outreach and Communication Representative. We have also Public Affairs Section, US Embassy, Kampala. Thank you, PMI team. Thank you, USAID Development Outreach Communication team and Public Affairs Section, US Embassy, Kampala, for being with us today. Over to you, Godfrey.
Thank you very much, Dr. Kasahun Pele. We also have a representative from the United Kingdom, the Foreign, Commonwealth and Development Office. And this afternoon, we have Grace Namata. We have a team from the government of Uganda that has provided us tremendous support, led by our Director General of Health Services, Dr. Henry Mwebesa. We have the Assistant Commissioner, National Malaria Control Division, Dr. Jimmy Opigo, as well as your team from the Ministry of Health. We recognize you very much this afternoon. We also have our partners, our colleagues from the districts that where MAPD has been implementing, represented by the DHOs from the districts where our offices were located. We have the DHO of Kabarore, the DHO of Hoima, the DHO of Masaka. We also have the DHO of Kayunga representing the central region, because the central region was actually hosted here in Kampala. We have the chairperson of Chotera district, who is with us this afternoon, and staff from Wobsana Health Center. We have a team this afternoon from the World Health Organization. We have also a team from UNICEF. We have a big team that is participating from malaria, the project itself, led by the prime partner, Malaria Consortium, which is led by the chief executive of Malaria Consortium. We also have partners that were within the program, including the executive director of IDI, the executive director of CDFU, the executive director of IDRC, the partner, a partner from Deloitte, and all the staff of MAPD are with us this afternoon. You are most welcome. We have partners that we collaborated with during the implementation of MAPD, including the country director of FHI, chiefs of parties from the rights projects, East Central, Rights East, Rights South, Rights North Acholi, and Rights North Lango, as well as a representative from Tasso. So you are most welcome, all of you. As I said, we have a tight program, and I would like to request that whoever I call on to make their remarks, be brief and stick to the time that was allotted to you. Let me take this opportunity at this juncture to welcome Charles Nelson, the Chief Executive of Malaria Consortium to make your brief remarks at this closure event. Charles.
Thank you, Godfrey. And it is sad in many ways we can't be together to do this, but as Chief Executive of Malaria Consortium, I'm delighted to have a few moments just to reflect on MAPD. It's amazing that the Malaria Action Program for Districts has been going for 5 years and we've come to the end of it. But a few quick thoughts. One, I think the impact that we have seen from the program has been remarkable, with mortality from malaria being reduced by nearly a half. I think it's seen a real increase in access of services for vulnerable groups and really built on that coordination and managerial capacity for, we hope, sustaining gains into the future, and seen some innovative mechanisms for capacity building for the private sector, strengthen the links between the district leaderships, health facilities, and communities. But at the end of the day, this has to be this has been a Ugandan-led systems thinking approach, and we've been promoting data-driven and results-focused activities, which have resulted in the impact that we've seen. Of course, in the midst of this, we've all been impacted by COVID-19, but despite that, we've still seen MAPD build technical leadership and managerial capacity at all levels, and supported resilience and participation in driving forward the malaria interventions despite that. And I believe also we've seen a tremendous growth in our partnerships. It's been an honor to work with the Ugandan government, the US government through PMI and through the team in Uganda. And we've seen building on the long-standing relationships we've been privileged to have with the Ugandan MOH, the district health teams, other health organizations, and our partners around Uganda. So as we come to the end of this program, we hope it provides that platform for real future success in prioritizing activity, working further on the phased out approach we've been using, and seeing a real sustainability and growth as we plan forward for the future of less malaria in Uganda. But thank you to all our partners. Thank you to the team in Uganda for all their efforts over the last 5 years. And it's been a great privilege and honor to work together. So thank you very much. Back to you, Godfrey.
Charles, first of all, for sticking to your time that you allotted. Thank you for providing the overall leadership for the program and leading the partners to come to the end of MAPD. We will now take a moment to watch a video. MAPD was involved in many activities, including support for health facilities, including the renovation of health facilities. And we'd like to play for you a short video of the work that we did in Wobusana Health Center 3. You'll be able to appreciate where we found it and the renovation that was done in order to ensure that we can be able to implement the malaria control activities effectively. Let's watch this short video.
Hello, my name is Chiza Dens, in charge of Wabsana Health Center 3. You are most welcome. Let me take you around the health facility. This is our waiting area where patients wait from, and then the MSAO here handles them first, does take some particulars of the patients, takes weight, height, records, and then from here, they'll be going to the next point. So they enter here, the MSAO finds out what is the problem. From here, if they need to go to the laboratory, they will be sent there. because we shall be going there. And if not, we shall be going directly to the dispensing window where we get medicines from. So when the patient leaves the clerical room, is directed to laboratory. And this is the waiting area of our laboratory, actually a new extension at OPD by MAPD. The patient is handled from here. That is where the specimen is collected from the patient. It is actually done from here. Okay, this is now our records office. It's where we keep documents. Treatment room. Remember, our patient, if they need some privacy while giving treatment, we actually bring them here. So this is our labor suit, newly renovated. This is a delivery bed, newly bought using result-based financing. And then from here, when a mother has given birth, she is transferred to this postnatal room or postnatal ward. And in that corner, we have fridges, vaccine fridges. We have the newly given fridge, the big one. Still at maternity, let me show you a placenta pit. This was the old placenta pit, almost filled up. Unfortunately, we got a new one. Okay, here is our new placenta pit, newly given to us by MAPD. Just like the old one, it is out of function. So we got this one for the maternity wing. 2 mothers can use this at a go. And we have a water reservoir. Water is harvested, rainwater. And this tank is as well connected to piped water. So once we use the toilet, this is where we wash hands from. Water is there. We have a newly given incinerator. I doubt whether in the district there is any similar to it. This is another pit latrine, still provided by MAPD. And we have a special provision on these ones. Here we have a water tank raised, also provided by MAPD. Here we have other tanks provided. MAPD has made it a point that we have enough water at this facility of Wabsana. This is Wabsana Health Center 3. Thank you for coming. I really appreciate MAPD under the support of USAID for making this a reality. Thank you. Bye-bye.
Wow, I'm sure you would like to join the clinic officer in charge of Wabsana to appreciate the US government in supporting the renovation of Wabsana Health Center. As you, I'm sure, saw through the video, you would see where we were coming from and where Wabsana is right now. I think it goes a long way to say how much MAPD has worked. Yes, principally it was meant to control malaria, but you cannot control malaria without using the entire system. And this is just an example of what the program was able to do. I would like to take this opportunity at this juncture to invite the Assistant Commissioner of Health Services in charge of the National Malaria Control Division, Dr. Jimmy Opigo, to make your remarks at the closure event of MAPD. Dr. Jimmy, you're most welcome. You're the person that has been taking stewardship of this program and providing the policy direction and support to MAPD. You're welcome.
Thank you, Godfrey. The Her Excellency, the US Ambassador, the CDC Director, the Chief Executive of Malaria Consortium and your team, UNICEF representatives, WHO representatives, distinguished persons, ladies and gentlemen. We know today we are celebrating partnership. We are celebrating impact. We are celebrating support we have received from the American people, which has been translated into results for the Ugandan people. We started about 7 years ago trying to conceptualize how we should transform malaria programming into a more effective approach and deliver results. We realized that it's very important to decentralize malaria programming, engage districts, build capacity of districts, specifically involve beneficiary communities, work in partnership with various actors, bringing together at the table various competencies, bring on board the private sector. And today, as we all know, we didn't only do that, but we delivered results. We achieved service coverage, high mosquito net utilization, availability of over 90%, availability and access to medicine of over 96%, not in any USAID PMI country. This is happening only in Uganda. The rest are 20, 30 percentage points behind this result. But we went ahead also to strengthen health system. We took a systems approach. Most important is use of data to optimize our interventions, to target better and deliver results. The impact is speaking for itself. In Uganda, we have halved malaria, incidence has reduced, and we are a very strong program. This is the only way we can appreciate the American people who have given us support when we translate the dollars into results. Going forward, we know we were impacted by COVID, but we managed quickly working with our partners to adapt and adopt our program quickly to remain available and effective and saving lives. Finally, the most important result of this work we have done together with the use of the American money is transforming our program to reduction and elimination. You know, we have introduced stratification, data-guided stratification. We have delivery models, and our program is poised for a much better success. We are looking forward to the upcoming PMI project, the PMI's malaria reduction activity. We are looking forward to continued collaboration as a country with the American people and the American government. We appreciate their effort to always give us mechanisms and partners with whom we can work together. And as we appreciate them, we like also to appreciate Malaria Consortium and its partners with whom they have worked to deliver a good project. Thank you very much. God bless us all.
Thank you very much, Dr. Jimmy Opigo, the Assistant Commissioner, Health Services in charge of the National Malaria Control Division. Thank you for those remarks. We sincerely appreciate you for your leadership, your stewardship of the program, and all the partners that work under your program. We appreciate your staff and all the staff of the National Malaria Control Division that we have collaborated with, that have given us guidance, both technical as well as support in the entry to the districts. It is time now, ladies and gentlemen. It's my pleasure and honor this afternoon to invite the U.S. Ambassador Natalie Brown, to make your comments, your remarks, and your speech this afternoon at the closure event of MAPD. Ambassador Natalie, you're welcome.
Thank you very much. Dr. Mbesa, Director General for Health Services, Ministry of Health. Dr. Apigo, Assistant Commissioner, National Malaria Control Division, Ministry of Health. Representatives of international agencies, the Malaria Consortium team, the District Health Officer, local council leadership in the community of Wapsata, distinguished guests, all protocols observed. Good afternoon. I am so pleased to join you in marking the ongoing success of our partnership in the fight against malaria. Today, we celebrate the achievements of just one piece of the United States' greater effort to combat malaria in Uganda, which in itself is just one piece of the United States' decades-long investment in the health of the Ugandan people. Investments that range from extensive programs to combat HIV/AIDS and TB, to support for maternal and child health, to programs to build the capacity of Ugandan healthcare workers, researchers, and public health facilities. Over the past 18 months, the United States investment in Uganda's health sector has expanded to include a close partnership with Uganda to combat the spread of COVID-19. The United States knows that none of us is safe until we are all safe, and I want to assure you that we are committed to supporting Uganda until this pandemic is brought under control. So returning to today's event, the President's Malaria Initiative, or PMI, works around the world to fight malaria. Since 2006, the United States has invested $450 million PMI to fight malaria. PMI's flagship effort in Uganda for the past 5 years has been the $40 million Malaria Action Program for Districts, or MAPD. This program was designed with a clear goal in mind: to reduce maternal and childhood malaria in 53 different Ugandan districts. I offer special thanks to our colleagues from the United Kingdom, which helped jointly fund this program. We are very pleased to have worked in close partnership with Uganda's Ministry of Health, with health facilities across the country, and with dedicated Ugandan health practitioners to implement this program. As I just said, the goal of PMI in Uganda is clear: a country where no child dies because of malaria, where health facilities have the medicines needed to save lives, and where enough trained health workers can properly diagnose malaria and treat every Ugandan who walks through the door. It is amazing to see what progress we've made. We've truly come a long way together in our joint efforts. Together, we successfully reduced malaria prevalence in children under 5 by over 77% between 2006 and 2018. Additionally, together we've reduced overall childhood mortality by 53%. While it may be impossible to put faces to each life saved, the data tells us a clear story. Today, thousands of Ugandan children who would not have had a chance to grow up are alive today thanks to our joint efforts and thanks to the personal dedication of many of you who are joining us here today. Malaria is a complex challenge, and no single intervention is enough to eliminate it completely. That is why this program has addressed malaria through dozens of different interventions. For instance, with other development partners, we recently concluded our 3rd universal bed net coverage campaign, providing a long-acting insecticide-treated bed net to more than 90% of Ugandans throughout the whole country. We trained health workers to prevent, diagnose, and treat malaria at health facilities, and strengthened districts in their supervision of health workers. We empowered community health workers to identify and manage malaria in children under 5, providing them with necessary medicines and tools. While it's great to recognize the significant successes we have achieved, it is also critical to look at the challenges that remain. The 2020 World Malaria Report shows that progress in malaria control has leveled off during the past 3 years. This is a cause for some concern, particularly since the COVID-19 pandemic has disrupted the provision of critical health services. This disruption means that we face new challenges to safely and quickly deliver much needed commodities like mosquito nets, testing equipment, and malaria treatments. What it means is that we still have more work to do. To overcome these challenges and to get back on track to reach malaria elimination, there are a few key things that we need to do. First, we need to maximize resources efficiency. This means a focus on increasing domestic revenue for health, all while ensuring that every dollar invested in malaria control is put to its best use. Second, we need to continually explore new technologies that will help us achieve better results in malaria control. There are many innovative examples, from improving home construction practices to serve as more effective barriers, to mosquitoes carrying malaria, to improving upon rapid research capacities to quickly detect mutations that make mosquitoes resistant to eradication efforts. Third, we need to maintain, of course, the gains we've made so far. So again, the United States applauds all of our partners for their many successes in controlling malaria in Uganda. Together, we have saved the lives of an untold number of Ugandan children, women, and men, and we can save even more if we continue our commitment to this effort. So today, I officially hand over the Wapsuna Health Center 3. It impresses me to recognize that this is just one of more than 1,600 health centers that the United States has supported throughout this project over the past 5 years. I have great confidence that this improved health center will give more pregnant mothers access to critical protection for both themselves and their unborn babies against malaria. Moreover, the center will allow more health workers to provide quality malaria services to the community. Overall service delivery at this facility will attain another level of excellence. So Harriet Nebukira, a mother of a healthy 2-year-old girl who received malaria services at this health center, said it well. The health workers at Wapsuna are very supportive during my pregnancy. I am so grateful they helped me to protect myself against malaria, allowing me to give birth to a healthy baby. So Wapsuna is just the latest of many examples of health centers and communities served by this project across 53 districts. So while today marks a transition point in our ongoing partnership to strive for our goal of eventual malaria elimination, it is not the end. PMI will continue in Uganda, and we will follow up on our work through the Malaria Action Program for districts with future activities. And we will continue to partner with Uganda and determine how we can best contribute going forward. Together, we can make a difference in the lives of Ugandans, just like Harriet and her daughter. And combined together, each individual gain we have made malaria control, including every mother receiving timely, quality malaria prevention services at the Wapsuna Health Center 3, will take us closer to winning this war against malaria. So I thank you for all of your efforts. I thank you for your commitment, and I very much thank you for your attention today. Back to you. Over.
Thank you very much, Your Excellency, Ambassador Natali, Ambassador of the US government to Uganda, for the very befitting words about the program, as well as handing over a newly refurbished, a newly renovated Wapsuna Health Center. I will not attempt to summarize the message that you've given us this afternoon, because every little bit of your speech was very important and very befitting at the closure of this very important program of MAPD. Let me take this opportunity to invite the Director General of Health Services of the Ministry of Health, Dr. Henry Mwebesa, to address the participants this afternoon. Dr. Mwebesa, representing the Ministry of Health and the government of Uganda at this occasion, I invite you to make your remarks.
Thank you very much, Godfrey. Your Excellency, Ambassador Natalia, the US government ambassador to Uganda. the CEO, Malaria Consortium, representatives of WHO and UNICEF, the Director, Malaria Consortium, East and Southern Programs, senior colleagues from Ministry of Health, in particular, Jimmy Opigo, who is the Program Manager, Malaria, the CEO, MAPD, district leaders, especially from Luwero, and our dear committed staff from Wabsana Health Center 3, all invited guests, ladies and gentlemen. First of all, ladies and gentlemen, good afternoon. May I request representatives of government or the district who are present in this meeting to make a big clap to this commissioning that has just been done by the ambassador. I think it can be heard. Let's have a very big clap for ambassador and the government of US for this generous contribution to the government of Uganda. So I want to thank you all for joining this very important meeting, and a special recognition to Ambassador Natali. Minister of Health appreciates your continued involvement in our health activities since you arrived in this country recently. We have noted with keen interest that you have been active and very much involved in all our health programs, and we don't take that for granted. We sincerely thank you and appreciate that commitment. Ministry of Health also notes that we are here to commission the renovated Wabsana Health Center 3, plus the closeout event of the MAPD project. The government of Uganda in general and Ministry of Health in particular appreciates the support from the US government through USAID and Presidential Malaria Initiative, which has been provided through Malaria Consortium and MAPD, to renovate and equip Wabsana Health Center 3 to this level of quality, as it was shown in the video when the in-charge was taking us through. This is a very important milestone in healthcare delivery in Luwero district in general, and Wabsana sub-county in particular. Government of Uganda policies to have a well-equipped and staffed Health Center 3 in every sub-county in this country. Health Center 3s provide most of the PHC services aimed at promoting health and preventing disease. If we look at an example regarding emergency obstetric care, Health Center 3s deliver the biggest number of mothers in this country. If you look at our report, annual health sector performance reports actually since 2017 through to 2020, you realize that Health Center 3s would deliver the biggest proportion of mothers, and it ranges between 51 to 53% over those years. So this is a very big contribution to emergency obstetric care and therefore reducing maternal mortality. Health Center 3s also play a very important role in management of the common childhood diseases, especially malaria and diarrhea diseases, and usually at the first level of contact after the VHTs, if we consider that Health Center 2s are being phased out. So after the village health teams, the Health Center 3s become the immediate second level of contact with the population, and usually providing services within 24 hours. So this also goes very far in improving or reducing under 5 mortality. I appreciate that through the pictures that we saw, we are able to provide rainwater harvesting, lighting, and all the required infrastructure to provide maternal and child health services in the health facility. On behalf of government and Luwero district, we assure the government, the US government, that we shall maintain the facility in the good condition in which you have provided it to us. So renovating Wabsana Health Center 3 by MAPD has contributed a lot in the direction of reducing maternal mortality and reducing under 5 mortality. And we thank the US government and MAPD for this very important contribution. On malaria control, Ministry of Health appreciates MAPD interventions in the 53 districts in which they have been operating during the project lifespan. We appreciate your interventions in skills development of our staff in case management for malaria. We are also aware that you did a lot of work in strengthening leadership at both the national and district level and facility levels for malaria control and management. Over the period, you participated in providing and distributing 6 million mosquito nets, initially 1 and then 5 million. But even more important, you did a lot of work in community approaches leading to strengthening behavior changes or health-seeking behavior for malaria control and seeking healthcare seeking behaviors of our people. And it is from that intervention that we came up even to develop it into the mass action against malaria, which was launched by none other than His Excellency the President. We are aware of the contribution of the village health clubs that helped promote sleeping under bed nets and behavior change. And even further, your interventions in supporting malaria control and malaria treatment through the private sector. As you all know, malaria remains one of the biggest burden of our diseases in this country, contributing to about 25 to 40% of OPD attendance and almost 25% of inpatient cases. So malaria remains a very big burden in this country. But we also appreciate that over the years, since 2011, there has been a significant improvement or reduction in the prevalence of malaria in this country. For instance, in 2011, the prevalence was around 42%. Malaria prevalence was 42%. In 2014, it was around 19%. And just recently, the malaria and AIDS survey showed that it was around 9% in 2019. So considering that MAPD was covering 53 districts, which is almost 50% of the total number of districts in this country. So your interventions in half of the country means you also contributed significantly to this reduction in the prevalence and therefore contributed heavily in improvement to health services in this country. And we appreciate you and we thank you. As MAPD, we thank Malaria Consortium and we thank the US government. So in conclusion, ladies and gentlemen, I want to thank US government and USAID for all the support to Uganda through very many projects on top of MAPD, because apart from MAPD, we have very many other areas which are being supported by US government through USAID and other interventions, but specifically in USAID, we have a number of interventions in disease programs. We have a number of interventions in quality of care. We even have a number of interventions or projects in health systems, including supporting human resources, and even more recently in global health security activities. So we really appreciate and we continue to thank you and we continue to appreciate all those interventions. But all we can say is that we shall continue to work together very closely with the US government to promote good health for our people so that the funds or the taxpayers' money from the US government does not go to waste. Finally, I want to thank Malaria Consortium and MAPD for a project very well executed and whose results are there for all of us to see. Ladies and gentlemen, thank you for being part of this successful project and being part of this very important closeout session or closeout meeting. I thank you all for God and my country. My Mr. Henry, Director General, Minister of Health. Thank you very much, Godfrey.
Thank you very much, our Director General. Thank you for the stewardship for steering the health sector in Uganda. You are the head of the technical program. You provide the technical guidance, you provide the policy. If it were not for you, MAPD would not achieve what it has achieved. We thank you so much for the support, and through you, we would like to appreciate the entire Ministry of Health for the support, as well as the government of Uganda for the support that was provided for the last 5 years to MAPD. MAPD has been a 5-year program, started exactly this day 5 years ago. It has been led by our chief of party, the one and only Dr. Sam Siduda Gudoi. Is going to take the next 20 to 30 minutes to talk us through the achievements, the successes, the lessons learned, as well as the recommendations for malaria control in Uganda that we have learned over 5 years in 30 minutes. I don't envy you, Dr. Sam, but since you have ably driven MAPD to the end, I'm sure you can precisely give us these in 20 to 30 minutes. Dr. Sam Gudoi, you're welcome on behalf of your team at MAPD.
Thank you, Chair. Ambassador Natalie Brown, the Director General Health Services, all of you, our invited guests in your respective capacities. Thank you for this opportunity to share with you the accomplishments under the USAID's malaria action programs, accomplishments that we are able to achieve because of the effective partnerships we've had with all of you. I'll be sharing on the project summary. We'll be looking at the data in terms of the project indicators. We'll share top line, the key approaches that worked. And then in the due course, we'll be sharing with you some links to where you can access some of the detailed information on the MAPD program, including the annual reports, including the guidelines, including the tools, and all other resources under this project. MAPD was funded by the President's Malaria Initiative, USAID, to the tune of $41.5 million. And we also received funding support from UK Aid, particularly in the first year. And the implementation of the program was led by Malaria Consortium with its partners, and most importantly, the stronger partnership between the government of Uganda at the national level, as well as through the 53 districts and over the 1,600 health facilities. The theory of change for the project was on morbidity and mortality, and we set out to reduce malaria-related morbidity and mortality, particularly childhood and maternal morbidity and mortality, through the implementation of technical interventions in partnership with the districts, as well as with the Ministry of Health, specifically the National Malaria Control Division. The focus was mainly on vulnerable groups, especially children under 5 years of age, pregnant women, especially of the reproductive age, but as well as the youth. And the total population was close to 14 million Ugandans, which is close to 40% of the total Ugandan population. This is an overview on the conceptual framework. It's much more detailed, and you'll be finding this in the details of the resources I spoke about earlier. Essentially, our work focused on 3 result areas: One was effective malaria prevention programs implemented in support of the national malaria control strategies. Two was effective malaria diagnosis and treatment activities implemented in support of the national malaria control strategies. And then three, building capacity of the National Malaria Control Division and the district health management teams to effectively manage and sustain malaria activities. To achieve these, we supported intervention of a set of activities at the various levels, national, district, as well as facilities. And we also had cross-cutting activities, mainly on behavior change communication, as well as engaging the private sector. And then we did interventions on gender and youth mainstreaming, monitoring and evaluation, building capacity for data, quality data collection, data use, and then most importantly, emphasizing collaboration, learning, and adaptation as part of our programming and implementation. The project area was mainly in the West Nile regions of West Nile region of Uganda, but then also in the central region as well as in the western region. In total, we supported malaria prevention and control interventions in 53 districts located in the Hoima region, Kabalala region, Kampala region, Masaka region, and Arua region. So we'll now look at performance, mainly looking at the data, what results we've been able to post. And first, we'll be looking at the results in regard to the project goal. And here we are seeing results relating to malaria death. You'll see from the baseline in program year one that deaths were very high, up to 2,000, but we reduced these steadily over the project period until this current year, where the deaths have actually reduced by over 50% when you compare with the baseline. I draw your attention to the current year, PY5, where we have now death reported for 3 quarters. And for the 3 quarters, the death reported are actually less than the death reported for 1 quarter in the first year. So if we extrapolated this, you will find that the death in the final year could actually be the death in just 1 quarter of the baseline year. So this is a tremendous achievement. It's a tremendous progress for the malaria program in Uganda. And indeed, when you compare the death per 100 admissions, you'll find that we are at 0.25 death, way above the national target, which is 0.4 death per 100 admissions. Similarly, morbidity, you'll see that in the first year, we had the very high malaria cases, which in the second year had been significantly reduced. But then you'll see that in the third year and the fourth year, the cases rose up, but in the fifth year, we have stabilized. In the third year and the fourth year, we had the countrywide epidemics. That's why the cases went up a little bit. But what's important to note is that while the cases actually went up, mortality went down. That meant that by the time the epidemics occurred, we had already strengthened our control capacity, we had strengthened the quality of malaria care, and that we are able to respond to the upsurge in these cases. Now, specifically in the different intervention areas, we look at malaria in pregnancy. We reached close to 1.4 million pregnant women with prevention services. And specifically, we're able to significantly improve the IPTP3 coverage from 2% at baseline to the current 68%. This one, if we measured the level of progress, is I think is in thousands of progress. It's I think about over 1,000 when you move 2%, 68%. And when we look, and here in this picture, you see a health worker appreciating the capacity building support under MAPD, and that is that quote. Then when we look at the early alliance, in the baseline year, we're at 48%. We were able to drive this indicator to 78% by the fourth year, but you'll see that in the fifth year, this indicator started dropping. Really, the reason here was because of challenges with the national airline supply system, but otherwise capacities in the districts, capacities in the facilities has been built to accurately quantify for their net needs to be able to deliver the nets to the areas that they need. And we are been able to deliver nets up to about 5 million in total, having delivered 3.9 million nets to pregnant women and children in the immunization and antenatal clinics, delivered close to 650 nets to school-going children, which was a very first kind of approach under this program. And then we delivered over 1 million nets through the universal campaign mechanism. And we're also able to work with the partnership, especially the Ministry of Health, to respond to natural disasters that struck some of our operation areas, and we distributed close to 65,000 LLINs. Again, this is a quote from a mother who has developed the culture of net use and appreciates the efforts by the government, by the US government, by the Ugandan government, and the MAPD program in ensuring that she receives the net and she prevents herself and the family against malaria. LLIN use is quite high at effective levels. We did 3 similar community surveys in different years, 2018, 2019, and 2020. And we evaluated the use of nets by children under 5 as well as pregnant women. And you'll see that in all the surveys, there was consistency of use of nets by the children and then as well as pregnant women. So it's no surprise that actually cases have reduced and that malaria-related mortality has also reduced. This is our capacity building efforts in case management. These are health workers undergoing training in the malaria laboratory diagnosis. And in this area, you can see that we have fully built capacity for diagnosis. Diagnosis before treatment was at 76% at baseline year. We quickly drove this to national target by the second year and to sustain all through the project period at around 100%. In terms of quality of care, you'll see that this is an indicator again, which was very, very poor at the baseline period. We're at 47%, meaning that at the time, 47% of patients who reported to facilities with the symptoms likely pointing to malaria were treated without any malaria test. Again, we worked on this indicator, and by program year 3, we had brought it down to 7%, and currently it's actually at between 2 to 3%, much above the national target of 5%. So case management capacity is fully built in the facilities and in the districts. When we look at the last 2 years, that was year 4 and year 5, we were challenged with the COVID-19 pandemic. However, we quickly adapted and we ensured that there was continuity of malaria services delivery through providing technical assistance to national level frameworks, guidelines, and job aids, which we quickly disseminated to the districts and the health facilities. We ensured that malaria was prioritized through the district COVID-19 task forces, where our teams were part of the task forces, and they routinely shared the progress of malaria services in those task forces and ensuring that focus was not lost. We emphasized the data because we wanted to be sure that there was no upsurge of malaria cases without us being able to identify these, and wanted to ensure that commodities were readily available, so stock tracking was as well prioritized. We rolled out offsite mentorship support virtually through the phone, through the emails, through WhatsApp groups, and then we also supported the districts to ensure that staff were available to continue providing the services. Certainly, we delivered national guidelines ensuring that the teams we are working with adhere to the standard operating procedures, and we even trained VHTs in continued malaria care. Most importantly, We forged new partnerships through the MasterCard Foundation that provided funding support to procure PPE that we distributed to the VHTs, complementing what we had through the project. Now, when you look at capacity building at the national level, as well as the district level, we provided technical assistance through policy and guidelines development, relevant surveys, and grant writing, especially to the Global Fund. The Ministry of Health and the districts were the face of the program, leading in trainings, leading in the disseminations of key practices at international events, leading in mentorships together with the districts as well as the facility teams. We are able to train tens of thousands of health workers in the different areas, in prevention, in diagnosis, in case management, as well as social behavior change. To note as well is that we trained 26 certified microscopists who underwent a WHO certified course, and having the number 26 puts Uganda at par with many of the sub-Saharan African programs in having a strong malaria diagnostic capacity. We monitored security of the commodities, ensuring constant availability, especially for SP, which is for prevention of malaria in pregnancy, but as well as the malaria rapid diagnosis tests and ACTs. We provided staff secondments to the Ministry of Health to ensure that staff gaps and technical needs were addressed counterpart, and then we emphasized collaborative learning and adaptation through the various fora, such as the technical working groups and RBM malaria partnership groups. And then we had integrated planning at the national level, as well as at the district level. And then we supported the conduct of relevant operational studies, mainly to ensure that the tools that we use for prevention, the LLIMs, as well as the SCTs are still efficacious and are still effective. We also provided in-kind grants to support data analysis, data use, diagnostic equipment, as well as facility improvements to improve the quality of services and ensure appropriate service utilization. We build capacity for social behavior change at the community as well as household and individual levels, with key messages at the different levels. For instance, a malaria-free village is a productive and vibrant village. For instance, if one member of the household has malaria, then we are all at risk. For instance, prevention is cheaper than cure. And in this sense, we are actually emphasizing the fact that malaria is not only just a disease, but indeed is an economic challenge. We build capacity for data monitoring and evaluation at all levels, emphasizing quality of the data, emphasizing sharing of learnings, and especially emphasizing data use through the district technical resource persons and the district by statisticians, as well as the facility staff that are responsible for data management. We supported the Ministry of Health, we supported the districts through quality regular mentorships, as well as HMIS quality assessments, data cleaning, data analysis, and data use. And through all these interventions and support, we are able to drive IPTP3 reporting, for instance, from 0% to the current 95%. We're able to drive weekly reporting from 55% to the current 86%. And indeed, we are able to use this data for timely detection and response where there are malaria upsurges. We build capacity for gender and youth through creating gender and youth-friendly environments within the facilities. We engage the youth in malaria prevention and malaria control, and we build capacity at all levels to ensure that data capture and data analysis provided for gender and youth. And this was embedded within our monitoring and evaluation framework. We are now closing, and we have transitioned the program for sustainability. And as you heard prior, the program design really had sustainability inbuilt, because we've implemented through the existing structures, the government, Ministry of Health, districts, facilities, and other partners have been the face of the program. As we transition, each of the 53 districts has been equipped with the relevant components that enable sustainability. For instance, they have the capacity, they have the plans for their malaria program. They understand quality assurance, and they understand the use of data in the malaria program. We have emphasized the multi-sectoral engagements, including the political and administrative arms of service delivery, and especially as well emphasizing that malaria is a big economic issue, and it should be placed high on the economic agenda. Data is critical, and we have worked with them to understand the data analysis approaches. We've provided data collection tools as well as data transmission tools. We have emphasized the aspect of strong advocacy, ensuring that there is institutionalization of the key approaches and that there is wider participation. We have emphasized strategic collaboration within their own localities, but beyond at the center, and being able to identify other resources that can support continuity. We have also emphasized the need for increased linkages between the communities, the health facilities, and the districts. This is part of the transition and sustainability engagements. And here we see the Assistant Commissioner, National Malaria Control Division, addressing a meeting in Vinyangavu, emphasizing all these elements. Now, we'll speak a little bit on the key approaches and lessons. And one, you'll see that we learned that malaria is an economic consideration, and we embedded this in all of the aspects of the program. Two, we learned that the Ministry of Health and the districts and the communities should be at the leadership of the program for continuity and sustainability and impact. We learned that technical skills are critical in the discharge of prevention and the diagnosis, as well as treatment services at all levels. We also learned that it's critical to engage the technical as well as political and administrative arms of service delivery in strategic planning, as well as deployment of resources. We also learned that data use is critical for prioritization, risk identification, as well as resource mobilization and resource deployment. We learned that health work mentorship on-site is more important rather than off-site trainings, which are disruptive to service delivery, and they are individual rather than being individual and institutional, which actually happens when you employ on-site mentorships. We learned that community and facility data especially should be emphasized in discussing community risks and enabling households to come up with timely and effective action. This is one of the tools under MAPD that focuses on the youth initiatives. Now, allow me, given the results, given the learning, allow me share with you some of the key recommendations. I said that each of the 53 districts now has a transition and sustainability plan, and they would like to recommend to the government of Uganda, especially the Ministry of Health and its other implementing partners, to support the districts to ensure that these plans are implemented as prioritized. We recommend that the engagement between the public and private sector is strengthened, especially in the areas of governance, to promote coordination, to promote quality of services. We recommend that data should be at the core of the malaria programming, and as well as informing adaptive management. We recommend that the technical resources available in the district should be supported to continue with the data analysis and take forward the malaria program. We recommend that we should go further beyond the facilities and have a deeper analysis of community-generated data so that the issues are investigated at source more than community data being used for indicator tracking. Specifically for malaria prevention, we recommend for sustained continued availability of commodities, especially commodities for prevention of malaria in pregnancy, as well as the LLIs. In malaria case management, we recommend parasite-based confirmatory diagnosis before treatment, emphasizing the use of the malaria RDTs, but as well as the microscopy, and ensuring that quality assurance is embedded in the diagnostic services. We recommend that the health centers are strengthened so they are the focus of future malaria case management, because most of the clients actually visit health centers rather than health centers and hospitals. We recommend that referral services are improved between the different levels, not only in terms of patient care, but as well as data analysis and informing action at the relevant levels. We recommend that severe malaria case management is prioritized with a focus on quality assurance through the clinical and mortality audits. We also recommend that in areas which are very endemic and hard to reach, we scale up the integrated community case management of malaria for children under 5 so that there's improved access and timely care for these children. In terms of monitoring and evaluation and surveillance, we recommend that we should do a deeper analysis of data at the different levels, including an analysis on the risks and behaviors of the human beings, as long as the malaria vectors. We recommend that we use data to tailor malaria interventions at subnational level so that it's not one shoe fit all. And also in the area of SPC, we recommend a strengthened interpersonal communication between the health workers and clients, and that the national strategy should actually capture this and it's driven down the user levels. And then we recommend that the communities are encouraged to participate in the malaria programming, and especially including the participation across gender as well as the youth, and that data should inform which particular localities in the villages that should be targeted for community engagements. We recommend that the program continues to invest in efficacy studies, especially for SCTs and the nets, so that we are sure we have real evidence that the tools we deploy for prevention and case management are efficacious and effective. In terms of capacity building, we recommend that the government ensures multi-sectoral collaboration, including the political and the administrative wing, to drive a strong malaria agenda. And we also recommend that the Ministry of Health emphasizes the countrywide rollout of the on-site mentorship for skills building of the health workers across the country, rather than the off-site trainings that have previously been happening. Allow me, Chair, to thank these entities that have provided us with the necessary support to register the results that we have shared with you today. First, I'd like to acknowledge the Ministry of Health, the districts, the facilities, and the communities for your involvement, for your engagement, and for the support. I would like to thank the US government for providing the funding through the President's Malaria Initiative, USAID. You did it all. I would like to thank Malaria Consortium and the MAPD partnership. You made it very easy for us to deliver this MAPD program. I'd like to thank our other Rollback Malaria Partnership colleagues, WHO, UNICEF, the Uganda Pediatrics Association, the Uganda Private Midwives Association, for your involvement and support, and being there always that we deliver this program together. And finally, but not least, please allow me to thank my MAPD team for the great job done. You guys are incredible. I indeed owe you. Thank you. Thank you very much.
Thank you very much, Dr. Sam Siduda Godoy, the Chief of Party, for the remaining hours of MAPD. Job well done. Thank you for working us through the 5-year journey. A tremendous job. You set out to contribute to the reduction of deaths, to the reduction of sickness, to the reduction of the burden of malaria in Uganda in specific areas. You actually have reported that you did that. You drove the population to use the services of malaria. You drove the population to adopt positive behaviors. And we have faith that these behaviors that have been imparted on the population will continue after the end of MAPD. You improved the capacity at district level because you are a district action program for malaria. At the district, at the health facility, and to a smaller extent at the community level. You've demonstrated that you use data, and you have actually inculcated the use of data at the health facilities and districts over the past 5 years. You transitioned this program into the national system, as well as into the district system. At Malaria Consortium, we endear learning. Indeed, in MAPD, there was a lot of lessons, a lot of learnings, and those have been documented. They have been used during the implementation of the program. They have been shared with the Ministry of Health. They have been shared with partners, and we have put a record of those learnings, and we will share the link. Thank you very much, Dr. Godoy and the team. I wish I would give you a standing ovation alone. I could do that. But since these days it's technology, I will thank you all for doing a tremendous job. We have a couple of minutes remaining, I think between 15 to 20 minutes. And we have lots of messages about the closure, about the successes, about the lessons, about the do's and don'ts that this program was able to learn. And I would like to take this opportunity to request the participants that we take time to listen to a couple of them. From Malaria Consortium, we have the technical director, and then we have partners of MAPD. We also have the districts. The much that the remaining time will let us go is what we will share. May I now request that we listen to Dr. James Venderana, the Global Technical Director of Malaria Consortium.
My name is James Kananurati Bendaran. I'm the Technical Director with the Malaria Consortium. I'm also the technical lead that provides backstop to the Malaria Action Program for Districts. The Malaria Action Program for Districts has prototyped and scaled up approaches to target interventions that can reduce the burden of malaria using a surveillance and response approach. This is critical because it means that we're able to take the interventions to the most vulnerable, but also ensure that the interventions are located where they are most needed. A pivotal approach has been to improve access and timeliness to parasite-based diagnosis. Rapid diagnostic tests, microscopy, the coverage of these tools have been increased in MAPD. The quality of external quality assurance has also been improved. The National Malaria Control Division and the Ministry of Health have an ambitious goal to eliminate malaria from Uganda. The Malaria Action Program for Districts has been instrumental in ensuring that malaria is used as an entry point to improve the resilience of health systems. By sustaining malaria control in the supported districts, MAPD has contributed towards Uganda's progress towards human and economic development. Importantly, during the time of the pandemic, the efforts that the project has put into the health system are ensuring that malaria is not a double burden to the already strained health system. Malaria, however, continues to be a constant threat. Multiple stakeholders have been involved and have contributed to the success of the MAPD project. A key success factor has been ownership and stewardship at district and national levels. Whereas the Malaria Action Program for districts is closing out, its benefits and impact should continue through the Uganda Malaria Strategic Plan. I'd like to thank you for all the collective efforts that have been put to eliminate malaria from Uganda. And I'd like to welcome you to listen to these very interesting presentations that highlight what can be achieved if we are all able to work together. Thank you.
Thank you very much, Dr. Tibenderana. I would like now to request that we listen to WHO, who provide the global technical guidance to programs like malaria control.
My name is Bayo Fatumbi. I am the cluster lead for disease prevention and control. But my primary focus is on malaria prevention and elimination. MAPD became very instrumental in reaching at least about 49 districts with the messages that come from national level, again, which is a reflection of the global strategy of WHO 2015 to 2030. So when we see partners, implementing partners like MAPD that can take the interventions down, that's what we are talking about. In 2016, we had, because WHO decided that surveillance should be a core intervention. Surveillance means getting evidence, actively going for evidence and data and using it for decision and actions. So MAPD came in as we were gathering the evidence as per what we need to do in terms of strengthening surveillance. So that's where MAPD came in. At that time, we were able to do what we call the system capacity assessment. So it wasn't difficult in 2018 when MAPD came on board to be able to take those messages down. So they were able to implement the surveillance strategy. They came with, and that informed a lot of interventions. They helped the district authorities to prepare their malaria-specific plan of action in the health plan, and they follow through. MAPD has brought an evidence that it can work, and what we are looking for is expansion of that activity. I think one of the strongest partners that the Ministry of Health has had, like I said, in terms of translating this strategy that we have. Again, let me also add that MAPD has helped with the evidence, with the experience in the field. We've been able to inform the new strategy that we have, 2021 to 2025. We either had implemented 2014 to 2020, but immediately, based on the experience, among others, we had Malaria Consortium under SUMA, which is supported by UK DFID. We were able to have what we call today MAM. MAM is Mass Action Against Malaria Initiative, whereby together with the parliamentarians, together with other key actors, UNICEF, WHO, USAID, and other NGOs, we've been able to say that truly we can reach those 7.5 million households. And that's what we call mass action against malaria. If the world is talking about high burden to high impact initiative today, that is the Roba Malaria Partnership Global and WHO. It is as a result of that experience that we now have this initiative called HPHI, which is out to address reduce malaria burden in the 10 most burdensome countries in the world. These 10, including India, makes 11. These 10 out of 11 are in Africa. Uganda is one of them that contributes almost 75% of the global burden of malaria. So MAPD came in together with other partners, helped us to come up that this thing is possible. And most of the experiences Uganda is sharing with the world is part of what MAPD had done. We are now moving in the new project of USAID PMI. We are moving closer to the community in the areas of surveillance, in the areas of community engagement. If we have not tested it at the district level, it will have been difficult to go down. And hopefully within the next, if we keep at it, hopefully within the next 10 years, I can tell you that the history of malaria in Uganda will be better rated. In Uganda, no thanks to COVID-19, no thanks to climate change that has increased the breathing sites and the increase in the burden of malaria. Speed is the word. We have planned a lot. Okay, we are rethinking malaria globally, or let me say in Africa. We want to see MAPD key into that. The speed, I repeat, is it. Yeah, we can plan. We keep planning. But we spend so much time doing a lot of planning. Let's go out there, try it out, and then we'll get there. Evidence generation that brought MAPD into limelight, experimenting the strategies at the national must continue. I must commend President's Malaria Initiative, PMI, under the collaboration, the support of the US government. Please, it must continue. The support needs to continue. And that is not in doubt, by the way. The new PMI Director Global has special interest in Uganda. This he has said severally. So I don't see that support drying out, but we want an intensification, an upscaling of that support so that the beautiful stories we've started writing in Uganda can continue. We will need not only the money, we will need more support for MAPD in the area of capacity building, exposure, areas of evidence generation. MAPD should be able to continue with the other partners to be able to help Uganda with evidence, like I told you, in the area of surveillance and response. If it is possible, let MAPD be supported to expand from 49 districts to probably half of the country, which will be like 70-something or a little more districts if we have 138 national. So I don't see US PMI reducing the support. All I'm asking is an intensification of that so that together we can write that story within the next few years.
Thank you very much. We have very limited time remaining, but I beg your indulgence that MAPD was working with the district, that we hear from the district, one district LC5 chairman before we come to the end of this closure event.
The names of Chindu Patrick Sekulo, LC5 chairman of Tetra District. MAPD has tried to help us a lot as a district because it was here and its target was about malaria. Before they came in, that is 2017, percentage of malaria in this district was like at 65%. So they helped us a lot because they started with the capacity building. They tried to engage our health workers. They tried to train village health teams. They helped us a lot. They even helped us to give us logistics. So many items were given to this district, like nets, some medicine. They taught our health workers. One, if somebody would have malaria, and like you have these herbal health workers in the district, they would take time to treat, and they would not know that if somebody is treated and is not recovering, should be referred to another health institution that can work better. But when they trained the VHTs, now we are very okay because they can even give some little medicine because now malaria is not rampant in our district. So we are glad that they tried to educate even the political wing, because as leaders, when you educate the leaders, then you have educated the community, because they go down there and educate the community. When we are, let's say, having ceremonies like burials, we have weddings, we always continue to tell people about malaria. They have even helped us to give us some computers. That is in order to keep our data. So we are glad that they have done a lot. And I know if they had not come in, we would be in a very bad state. I know that MAPD, here it has left the district, but I would like once again to thank them for the good work they did to our district. And if there is any chance, this one I want to repeat it, and they have, let's say, another project, please, they should consider Chotega, because we work as a team, the political wing and the health team. We work as a team, so I would be glad if at least they consider Chotega. I would like to thank USAID for supporting MAPD for the implementation of malaria reduction activities in our district, and I pray that they come back again.
Thank you very much, Chairman Chisekuro, Chairman LC5, Chotara District. We are finally coming to the end of this event. I would like to thank all of you for participating, for listening, all the presenters for the excellent presentations, as well as for keeping time. We are just a couple of minutes over time, but I think we've managed our time very well. In order to close our event, I would like to invite once again the Assistant Commissioner, the National Malaria Control Division of the Ministry of Health, Dr. Jimmy Opigo, to give us the final closing remarks of the closure event of MAPD.
Thank you very much. Very great event. As the saying goes, every good thing has a beginning and the end. As we celebrate the end, we need to know that behind this big success we have been sharing have been some people whom we have to appreciate. Behind this is the American task. Behind this is the willingness to support humanity around the world. Behind this is the spirit of global health security. Behind this, we know, is a group of technical people who have put together a very great mechanism guided by a very clear strategy, program logic, theory of change, which has delivered this. Behind this are people working in the US mission, many of whom are in this call, and the many people, including communities, districts, and the MAPD team. We need to appreciate them. As we close, we need to know that the work is not completed. Malaria still exists. We have dented it, but the commitment, fortunately, exists. As you have heard from Her Excellency, the US Ambassador, the US government and mission is committed to move with Uganda shoulder to shoulder and the world until when malaria is defeated. That is so exciting to hear. We have learned a lot of lessons, but beyond that, we know that currently we are challenged by COVID. That notwithstanding, we appreciate that we have been able to adapt and adopt and move on. The future is still beckoning. Our commitment has to continue. In the future, we have already designed the future. We know that we now have to move to a holistic approach. We have to move away from one size fits all. We have to have a comprehensive approach. This has already been well designed. We also know and appreciate that the US government is about to roll out a new project, the PMI's malaria reduction activity. And when this comes, we still invite all of you to work with us. The commitment of government has already been provided. The relationship between the government of Uganda and the US government is upbeat, as we know. And this collaboration is going to continue until when we defeat malaria. I would like to thank everybody, UNICEF, Malaria Consortium, MAPD, my team with whom we work, people like partnerships. When we deliver result, we impact communities, we change the world, we account for resources, and those who give us money will continue supporting us. I would like to thank everybody. Let's continue this spirit, and thank you very much.
Thank you very much, Dr. Jimmy. I thank you, all of you that have participated. Thank you very much. Thank you for your time this afternoon, and best wishes to Uganda in its control and its fight against malaria on the new journey to elimination of malaria in Uganda. Thank you so much.